Good afternoon. Hello to everybody. Thank you for joining this mini symposium organized by Medtronic. It will be about office hysteroscopy, a subject that has many wins, and we will discuss these wins after each other. And the first speaker I want to introduce, although I don't think he needs much introduction, still it's so common to introduce someone and don't let him stand here just by himself. Well, actually, my name is Marc-Hans Emmanuel. I'm from the Netherlands. Probably most of you know that. Anyway, Attilio, he's at present a full professor of obstetrics and gynecology and the director of his residency program of obstetrics and gynecology at the University of Naples. He's chief of the hysteroscopy and maternal and child health department at the University Hospital in Naples, the Federico II in Italy. And he has been a member also at the teaching faculty at the unit of minimal invasive therapy and endoscopy at the training center while he was at his Royal Free Hospital time in London in 2003. So he is already for a very long time one of the opinion leaders in the field of hysteroscopy, and I'm very happy that he was gratefully spent his time to this symposium to say something about the wins for the patient. So Attilio, the floor is yours. And yeah, as you have seen, we start a little bit later, but we try to stay on the schedule of 15 minutes per
Thank you.
presenter. Thank you.
Okay, thank you, Mark. So, if we are here today, it's because of you, however. So, because of Mark and his great mind. He's one of the guys who had the sixth sense to anticipate and predict the future. No, Mark? So, we are going today probably to say something that you have listened a lot during this Congress and other Congress, but still, office hysteroscopy is not really widely diffused all over the world. First of all, probably next Congress, we have to call the Congress for outpatient hysteroscopy, because if we check this publication, so office is just when you do in the medical practitioner professional premises, so outside the hospital, outside the freestanding surgical center. Generally, what I will present you that we do at University Federico II of Naples is the outpatient clinic hysteroscopy. But you see that according to the pain management in office in outpatient clinic setting, you can do the same up to the level 3A, which means that you can provide up to oral or inhalational medication. In some countries, like for example in Belgium, you can do in office outpatient up to level 3B, that is parental medication with sedative effect. So, but what is important is that in the past, when I started to do office hysteroscopy, outpatient hysteroscopy, all the presentations were about pain management, How can you manage patient when they start screaming, when they complain, when they have pain? So that's why it's been important that now the setting in this new classification system has been based on the way in which you manage pain. And pain cannot become anymore, as it's been in the last 15 years, the alibi of most doctors that they prefer to bring patients in the operating room under GA because they were the good, that they do not want to cause pain to their patient, and Attilio, Mark, or the others were the bad guy who wanted to cause pain to the patients. This is not like that, because we will see that now our patients that ask to have the procedure performed in outpatient setting. Then, of course, if you work a lot in outpatient setting, you can maximize which are the possibility of outpatient hysteroscopy, not only to confirm the sonographic diagnosis, but even to do the treatment of some pathology. The best way, I think, is to show with a real-life video what is normally what we do in our ambulatory. There is nothing extraordinary, but everything is maximized in order to improve the chance of success of the procedure. What is important is that you have to explain to the patient what you have to do and before she signed the consent. And of course, in order to reduce time of the procedures, the tissue removal devices become a great tool preferred by senior as me, but mostly by young generation in terms of reducing time of the procedure. The main limiting factor of outpatient procedure is time. And if you can reduce time, the first time, Mark, that they show me your device, your prototype, I said these words, it's terrific. It is going to destroy the market. And it has been like that. Because I strongly believe that it was not the pain the problem, but it was the time. And because we were limited in terms of instrumentation, in reducing time of our outpatient procedures, when I saw this instrument, I said, oh, probably we will change our way of approaching our pathology of our patient. And you see that in less than half an hour, since the patient comes in and comes out, you can resolve the problem of the patient. So it's a win. We know that probably this approach should be the better, but it should be better for the doctor. We will see later for the hospital, but let's try to imagine why it's better for the patient. It's better for the patient because now, and probably this is the effect of the social changes that we had throughout the years, now women work. Thanks God. So they work a lot. They do not want to waste time. And you know that when a patient needs to undergo procedures under general anesthesia, the main complaint of the lady is, doctor, how many times I should come to the hospital? Why should I have blood examination? Then she has to come back to do the consultation with anesthesiologist. In many centers, in order to increase the reimbursement, the patient has to spend at least 1 or 2 nights in the hospital in order that the procedure is cost-effective for the hospital. Patients do not want to waste time. When you ask patient which is the best desire that you have, because of course it's mandatory that you have to resolve the problem, but she wants to come back to her routinely activity in the shortest time as possible. And with office approach, we can guarantee this. In the past, I saw that in the last 10 years it's changed. Even from social point of view, the way of approaching the treatment of intrauterine pathology. In the past, to remove a polyp, there was all the family with the patient. The husband, the children, the grandmother, because it was perceived such an invasive and painful procedure. Now lady comes alone, and they are only asked sometimes that we have to sign a certificate just for having the permission by her work for a couple of hours. They do the procedures, they come back to work or to their family. And most of the time now they come alone. When your patient undergo anesthesia, they need help, they cannot drive the car. So it's a problem, it's a social problem even for the family who has to come with us. And keep in mind that anesthesia probably something that has some hidden danger that with office approach, without any kind of anesthesia, we can avoid. Of course, if you ask to patient, every patient, even we, when we went probably for some operation, even from good reason, when we go into the environment of the operating room, everyone is scared. When we take a plane, everyone is scared, even if you are in business class. Because you always think that something can happen, that you are going to sleep, and something can happen. When you are in a friendly environment, as I showed you yesterday, that we are trying to use some visors at the moment in order to improve the compliance of the procedures. And you create a comfortable environment, no speaking at the phone, the door opening and closing, so people speaking, chatting. You create a comfortable environment. You can create a real patient-friendly environment, and you can improve the chance of success of your procedure. And you have also to do This is why I'm very proud that with me and my team, we create a very easy and quick pathway for the patient, easy access, easy and very motivated counseling to the patient, and also to be available for any question after the procedure, available sometimes even at phone if the patient has some problems after the procedures. Patient has to perceive yourself as a friend, not like an enemy. Of course, there are some rules that sometimes we forget when we do hysteroscopy, that in office setting are much more important. Think that patient, probably they cannot judge if you are good or not in removing the polyp, but they can judge if everything is dirty, if you are not polite, if the environment is not comfortable. That's why when you explain the procedures, I always say to my trainee, this is the most important part. Don't say to the patient, please sign the consent that we do. It's important that you create a comfortable environment during the procedure. We saw yesterday the visor. We can have an assistant, a nurse, a medical student to do the vocal local. And please, and with Medtronic, we are doing a great job to promote with Niall, Igor, Jacqueline, all the pathway for vaginoscopy. Vaginoscopy is mandatory, wherever instrument you are going to use. But you know why? Because every patient is scared when she comes on the chair of hysteroscopy. If you can relax since the beginning, and you know that vaginoscopic distension of the uterine cavity is completely painless. You can stay 1 hour in the vagina of the patient. Sometimes at the beginning it seems that you are for an hour, because in your learning curve at the beginning you cannot find the external uterine ostium, but this is not painful. So I always recommend to my young junior doctor, please speak to the patient, explain that you are checking what is going on in the vagina, if there is something. And then you identify the external uterine ostium and you go inside the cavity. Don't make patient wait, even if patients are motivated to wait when they know that you can resolve the problem in one session. And probably with better smile, I should change this picture since I've lost weight. So, but Bruno, works for you for next year. Then, of course, the training is important. Training is mandatory. I always say that when people say, which is the things that you are doing better in your life? Training. Because I strongly believe that training is important. And of course, training in vitro, everyone can do. Training in vivo, mostly when the patient is awake, is something very, very complicated. I learn now to do hysteroscopy in the opposite way, because most of the time I'm in the opposite way, and that's why now I'm able to use right and left hand, because most of the procedures are done by young junior doctors coming in this institution. This is not young doctor, this is Milind Telang. He came in my institution to learn hysteroscopy. Now he's one of the most well-known hysteroscopy throughout India. So when you find someone that really gives you the power of the instrument, this is the best teacher that you can have. But a few of us, we want to waste time to teach people. And for me that I work in university, this is a mandatory. That's why I'm very proud that I'm the director of the training program, because I strongly believe that training and the best master is the master that put himself 10 steps behind his assistant. But things in our life, how many doctors really give the power of having the instruments in your hand? A few. And not because we are here in a symposium of Medtronic, and I thank all the staff for arranging, but why TrueClear, and I would say even the other tissue removal devices have changed our life. I can tell you the TrueClear because I have a direct experience, and I can tell you what I really use in my life. And I use independently on the other company, independently on the course that I arrange, because I strongly believe that tissue removal devices are a must in our outpatient activity. Because even in the past, when I was used to perform hysteroscopy only with 5 French bipolar electrodes, however, I didn't use no analgesia, no anesthesia. It's the same with the TrueClear. This is not a great advantage, but it's an advantage that I'm not going to use electrosurgery. And when I ask to my fellow, which instrument you want to remove the polyp, most of the time, they prefer the TrueClear because it's easy, because you can go in and out from the uterine cavity only once, rather than the standard instruments. And when you are the leader of a group of young doctors, because the mean age in our institution, in my center, is less than 30 years, it means that you have to offer young generation the best for performing hysteroscopy that are effective, but even safe. And they have to feel confident in doing this kind of procedures. And you know that you have a literature showing that the learning curve is shorter, but shorter does not mean that you don't need training, because complication can happen also with the tissue removal device, but this is not a problem of the tissue removal device. It's the problems of yourself if you are not doing the proper training to get into the uterine cavity. Whatever car you are driving, if you don't know how to drive, you can do an accident. You can do with the Ferrari, you can do with the standard car. But you know that in the last years, thanks to these two innovations, mini resectoscope and tissue removal device, so we have avoided use of resectoscopic surgery and operating room. And we reduced the waiting list, we reduced the cost. The lower number of insertion, we said before, that it, of course, simultaneously cut and remove the fragments, you know, and it's easy that you don't have to go in and out to remove all the chips, and we know that this is a problem. The problem of electrosurgery is not because electrosurgery is dangerous, but because in not expert hands, the not proper use of electrosurgery can damage the surrounding healthy endometrium, can damage the myometrium. Not all people are expert, and in the beginning of your learning curve, if you have to remove the polyp without damaging the healthy endometrium, the healthy myometrium, better that you use tissue removal device that you are not going to create any problem. Of course, less complication, but less complication does not mean zero. But of course, not using electrosurgery, you reduce of a great amount the rate of complication. And which patient wins more? And I finish. When we have polyp, and when people say, yes, but polyp, even in my center with, between bracket, expert center, are 60-65% of procedure. So in your training program, if you learn how to remove a polyp, it means that you are able to do 60-65% of your procedures. Better to learn how to do a polyp than not to do a septa or a type 2 or type 3 myoma. And the visual DNC, I'm sure that it will become one of the main indications of hysteroscopy throughout the years. In the United States, they did a great job with tissue removal device. Tissue removal device represent 80% of operative procedures. And they have nearly completely abandoned blind technique. They did a great job, even better than we did in Europe. Probably in Europe, we have quantity, quality of operator higher than United States. But they did a better job in order to reduce blind procedures. And visual DNC that takes the advantages of removing a large quantity of tissue from the cavity, but under vision, not in a blind way, is the best way to reduce blind procedure. And last but not least, the first paper about tissue removal device were about retained product of conception, because you have a higher risk of adhesions, because it's a gravid or post-gravid uterus. It's not a matter of electrosurgery or tissue. So the problem is that this uterus is more keen to develop adhesion. In this case, electrosurgery is not indicated, but not because it's electrosurgery, because in this specific case, the rate of adhesions is higher. That's why tissue removal device you must use in this case in order to do the best for your patient. Thank you very much. You cannot introduce yourself, Mark, so please let me to introduce. I didn't prepare your CV as you prepared with mine, because I was not prepared, but I think that there is something that I want to say of this guy, because he represents one of the bright minds that we met in hysteroscopy. Because, and I put in a video that he showed to his family, so he asked me, I was very proud that he asked me a video that I presented a few years ago. Because you is the inventor of the Trochlea, why we are here, and with this invention, he has changed the way of operating in hysteroscopy. And this is something that it will be important because he will be remembered forever. I hope that he will be with us for at least other 30, 45, 50 years, but he will be remembered in all the books. And this means that you did the history, and you did, Mark.
Well, thank you very much, Attilio, for this wonderful introduction and your passion about this technique and your I would say Italian-style introduction of this symposium. It's really a great honor to be introduced by you. Now it's going to be a little bit different, a little bit more Northern European, so a little bit less passionate, a little bit less emotion, but still, well, the subject I will cover is the win for the clinician, and I think we can do that quite quickly because we are running a little bit out of time as well, but that's not the main problem. So let's see. Well, this of course is quite clear for you all. You know what amazes me that 20 years ago it was already quite nicely demonstrated by the group of Sean Duffy from Leeds in this wonderful randomized controlled trial. You know, I'm fond of randomized controlled trials. That's probably a habit of Northern Europe, I would say. But anyway, they showed very clearly already 20 years ago that office hysteroscopy versus daycare hysteroscopy was the way to go. It was very clearly that patient satisfaction was much higher in the office hysteroscopy group, and they recover more quickly. Requirements of analgesia were similar in both groups, and nowadays with the miniaturization of the instruments, we hardly need any anesthesia. Well, what was at that time already 78% of the patients considered the pain comparable or even less than usually experienced pain during menstruation. Postmenopausal women may benefit less, but that's history, I would say. Nowadays, that's not true any longer because the size is diminished of the instruments. And this is a very elegant meta-analysis and systematic review as well from Canada. And well, this young fellow beautifully showed us how effective and how good office hysteroscopy is when you compare it to the classical way of doing it in an operating room. And I think we should not talk any longer about the classical way of doing hysteroscopy, because the only way of doing hysteroscopy, if you ask me, is do it in the office. There's absolutely no need to bring the patients to the OR. So what you see here is the treatment success is in favor of outpatient, the adverse events are in favor of outpatient, and the patient satisfaction is exactly the same, measured in this systematic review. And I would say if you ask nowadays patients to compare an office setting with a daycare, I would say most of them, almost all, would like to have this done in an office hysteroscopy setting. How do you get it right? The best optimal outcome you get when the setting is okay, when the physician is okay. Of course, there is a selection of patients. Some patients simply are not suitable for office hysteroscopy. Some patients, we all know them. They're very difficult to examine, and be careful with those. But most of the patients are, and then you should do the right procedure with the right equipment. And I agree, of course, but if I talk about hysteroscopic morcellation or tissue removal systems, you should be aware of my disclosures, of course. We train our office staff as well, not only the residents, but also the personnel, the nurses. The nurses know exactly what's going to be, what's going to do, what we exactly do. They even are trained on these computer simulators, how you should manage a hysteroscopic morcellator or a tissue removal system, because it's not only in our hands, it's in the hands of our staff as well. They should make the right connections, etc., etc. So they need to be very well trained. The the primary difficulty in office hysteroscopy is the management of patient discomfort, and anxiety, and that's where I realized that Attilio mentioned already the verbal anesthesia, which is very important that your staff gives the patient the feeling that they are at ease, and they very thoroughly discuss the procedure with the patients also in advance. We always ask the patients to meet the staff as well, and then they tell together with us exactly what the patient will hear, see and feel, what she can expect. And of course we always tell them that the procedure will not be much more painful than a natural period, and fear can exacerbate the pain, you know, so that it's probably, if the patients are more relaxed, they feel less pain. The camera and monitor is something we ask the patients whether they want to see the imaging. We know that there is a randomized control. You know, in Britain they randomize everything. So this is randomized in Britain as well, here in this group. And they found that if you let the patient see the screen and the monitor, then they describe the pain as more positively, especially in terms of comfort, reassurance, and encouragement of the treatment, especially if you see that your polyp is gone with TrueClear in 1 minute. You know, it's very convincing, or even less than a minute. It's very convincing that how accurate and how well equipped and well trained the whole group is there, and that reassures the patients enormously. On the other hand, virtual reality can help nowadays also, because some patients don't simply like to watch the screen. And the first thing I tell them that the image is enormously enlarged. What they see, the circle normally is a diameter of only 3 millimeters, while for them it looks huge. And if you see such a polyp and there is some bleeding and some vessels, people might be a bit, you know, afraid as well to look at it. So many of them don't want to look at the screen, and we offer them virtual reality. And, you know, we have the feeling that the more relaxed the patient is, it's easier for the physician as well. And I had to talk about the win for the physician. Well, this is a randomized controlled trial from Britain also, where they randomized the use of virtual reality for acute pain in office hysteroscopy. And what you actually can see if you have a situation like this, and it's measured quite well, you will notice, well, here you see that the patient is fully awake and at ease, and she's observing something completely else and having music, but it's the sound is lowered as well, so we do have contact with the patient. We can speak to them, we can tell them also what they can expect at that moment, but it relaxes them very much. And you see there is hysteroscopy done in this patient while she has the virtual reality goggles on. What is measured in this randomized controlled trial, that the worst pain scores were significantly lower, the average pain scores were significantly lower, and the anxiety scores were significantly lower in a group who wants virtual reality. I have the feeling that you always should ask the patient, what do you want? Do you want a virtual reality goggles, which distracts you from the procedure, or do you want to see exactly what we are doing inside your uterus? And let the patient make the choice. Don't choose for the patient. I was trying to make a list of what is the true advantage for the physician, and then especially focused on the physician during office hysteroscopy compared with hysteroscopy in the operating room. And then suddenly I said, why not ask ChatGPT? So I asked ChatGPT exactly this question. What are the advantages for the physician during office hysteroscopy compared with hysteroscopy in the operating room? And it is amazing what ChatGPT will do. This exactly is what ChatGPT, where it came out with. One, the cost. Office hysteroscopy is often less expensive. Yeah, we all know that. But it's nice that it's confirmed by computer as well. You know, it doesn't require operating rooms, no general anesthesia, and no additional staff. Well, not as much as in the OR. convenience, office hysteroscopy can be performed in the physician's office or in the clinic, which means that scheduling is so much easier because it can be done in your own setting. You don't have to travel to the hospital, for instance. And it saves time, enormous time, not only the procedure, but also the number of consultations is much less. If the patient sees exactly what was done, you don't have to explain or afterwards what exactly was done. So if the number of procedures and consultations is lower, it will save so much more time than only during the procedure. Patient comfort, you know, it reduces the risk of complications as well, because there are less complications if you have no general anesthesia or no OR staff available. And there is increased control. The physician has greater control over the procedure without the distraction of hospitals or operating rooms. You know, quite often in an operating room, people are coming in and out and distract you, while in an office setting, it is your own place, and the whole staff knows there's a hysteroscopy going on. So don't enter, right? The ACOG committee has an opinion on the use of hysteroscopy for the diagnosis and treatment of intrauterine pathology as well. And apart from everything which has been proven by randomized controlled trial, this committee states that other potential benefits are for the office are patient-physician convenience. And I agree completely on that. And I was very happy to read that the potential advantages of the hysteroscopic tissue removal systems were acknowledged by this committee as well, in, you know, shorter operating time, higher likelihood of complete resection, you know, especially the endometrial polyps, of course, retained products of conception, and the small type 0 and 1 fibroids. And you know, it's exactly as Attilio showed you, it's quite clear that the advantages are huge for TrueClear in an office setting. And I can tell you, we would stop doing office hysteroscopy if we would not have tissue removal systems available. In our center, office hysteroscopy is the way to go for all polyps. You know, size is not a problem any longer. You can remove a 3, 4, 5 centimeter polyp within minutes with a tissue removal system. Just wait, activate the morcellator, and the job will be done by the technology itself. Basic rules. Some of them have been covered already. Correct indications, of course, proper technique for respective pathology. Maintain uterine muscle integrity, of course. The deeper you go into the muscle, the higher the chances that the patient will feel the procedure. And that's especially true when we do type 1 myomas. If you go deeper into the myometrial wall, there might be some pain because you get closer to the serosa. And of course, always work at the lowest pressure where you have a good visualization. So avoid over distension of the uterine cavity. Vasovagal syncope or a collapse, you know, sometimes it can be quite confrontational, especially for those who are coming together with the patient, the husband or a friend, or you know, that it can be quite something which is impressive, because if they really faint, then, you know, they might need atropine. But the question is, with intrauterine procedures, is this a real complication? Because we know this happens for placing a simple IUD as well. So, of course, we don't prepare the patient on it. We tell it can happen, but it is just, you know, it is a minor issue, although it can be very impressive for those who've never seen it, but it's not a real complication. It is something which can happen not so very often, I would say. Thank you. Well, take to work. My last slide. I would say the most important one, perhaps, of course, the win for the patient, but that was not my subject. But the ease of scheduling patients for us as a team is extremely simple. You have your own hysteroscopy room, and you're the boss in your own hysteroscopy room, and you don't need any other members of the hospital team where you have to schedule with. There is less time needed for procedures and consultations. I've told that already. You can do more patients in a shorter time. There is an increased accessibility due to a lower cost, and time spent at the hospital or surgical center, it's more familiar, comfortable in an office setting for both patient and physician, and more convenient means less visits, less consultations. Patients come in and out. There is a reduced pocket expense for patients as well because it is cheaper. And especially in my country at this moment, office hysteroscopy is reimbursed better than hysteroscopy in the OR for the doctor. And I think insurance companies make a very clever choice by doing that, by promoting office hysteroscopy to the doctors as well. This probably is one of the slides I'm really proud of. This lady was so at ease when we were removing her polyp with TrueClear that she actually was videoing with her iPhone her own removal of the polyp. Can you be more at ease when you are willing to do this? I don't think so. Thank you very much for your attention. Right, the last speaker. I would like to introduce her as well. And I have a very short bio. Patricia Nervo, she works at the University Hospital in Liège in Belgium, which is, I think, the closest French-speaking town to the Netherlands. Yeah, probably it is. But it's only, 15 kilometers to Maastricht. And Maastricht is very Dutch-speaking, but when we cross the border, they speak immediately French. Well, my French is very bad, I'm sorry. But she works at the University of Liège with Professor Nizol and Professor Kridelka. She was a fellow at Clermont-Ferrand from 1999 to 2001, you told me? Yeah, at Wattier. I know Wattier. And she's responsible for the surgical minimal invasive department of benign gynecological diseases. And she started to use TrueClear in 2018 only, but she's one of our best performers. Thank you very much.
Thank you. Hello, thank you very much. It's really an honor here to be with two famous hysteroscopy, so thank you very much. So the subject of this topic is trying to understand if there is a financial benefits during the TrueClear, and if it's in office practice could have an advantage for the hospital. So, first of all, you know that abdominal uterine bleeding has a big incidence and prevalence for all the women, and this has a cost, a financial cost, for each procedure. So we need to understand what we can do to lower this cost. So to do that, we must have an impact and an action on each step. The first step is to have a diagnostic very early, to treat this lesion in the early stage with a precise procedure and to have an adequate treatment. In order to perform, to offer a quality of life, to reduce the absenteeism of the patient due to the lesion, to the symptom, to the pathology, but also due to the procedure you used during your surgery, and to prevent and to reduce the adverse event. So for that, you must choose a treatment who will be early, adequate as soon as possible, with poor or no recurrences. And all these things had, the medical care had a financial cost, but not only for the hospital, but also for the society, because the absenteeism, the less working time are induce some problem, financial problem, but also for the insurance company. So this slide is only to to explain you what you know, that the estimate cost of bleeding due to the uterine leiomata is important. And when you are looking in the US, you see that the treatment of the uterine bleeding due to the fibroids has the second place in the estimate annual cost in the USA. So to understand what you must do in the future, we must have, we must know what happened in the past. The first hysteroscopy, in operative hysteroscopy, was made by Pantaleoni in 1969, and he performed the first hysteroscopy. It's the first person to see what happened into the uterine cavity without any anesthesia, and did this procedure in the office. After, following this event, many technology and the technique improved, and we saw the hysteroscopy, diagnostic or operative, arrive in the OR. And in the USA, there is a changing pattern of change the procedure from the OR to the ambulatory. So you can see that the activity of the ambulatory setting change and grows up 3 million until to 27 million. And why? First of all, because the ambulatory addition pattern was identified, and indication of additional operation during in ambulatory was choice and made because the patient wanted to be operating in the ambulatory, and maybe because the surgeon wanted to do like that. But the inpatient rate did not change. And why? Only because you offer most place in the OR when we remove all the operation in another place. So in the USA, they understand after, when the movement changed from the ambulatory into the office, and immediately the USA understand that the reimbursement should be a good idea. So when we continue the story of the hysteroscopy, you can see that after the end of 19, you can see that they stopped to make in the OR most of diagnostic and operative hysteroscopy, and all of them was made in the ambulatory setting. And you can see that arrive some person who did this hysteroscopy in our patient clinic, or not at that moment in office. And you can see in this paper that the cost effectiveness of changing the setting of your hysteroscopy have a cost. When you are looking this, you can see that it's less when you are doing in office hysteroscopy because you have not the anesthesia cost and not the hospital cost. In Australia, last year, they made a paper, and we must know that despite the advantages of ambulatory hysteroscopy, in Australia, the hysteroscopy under general anesthesia is still the predominant form of intervention. So that's why in Melbourne, they try to make a prospective study and to make to try to analyze some criteria. The first one was the satisfaction of the patient who had an ambulatory hysteroscopy. And you can see that 94% of patients said that they would undergo an ambulatory again if hysteroscopy is needed in the future. And more near 100% patients said that they would recommend ambulatory hysteroscopy to their friend. That's a good result. But also, they make an analysis about the fluctuation between the financial cost in the ambulatory and in the OR. And when you can see, it's that the most biggest cost is the theater cost. So what you know is that the conclusion of this paper is that the ambulatory hysteroscopy is safe, we know that, effective and accessible alternative to hysteroscopy under general anesthesia or Reiki anesthesia, but we need to be supported by the government, by the financial help, because this kind of procedure have a lower complication rate. Also, it's not only the financial cost of the room, of the setting when you made your procedure. It's also the procedure itself. When you make a procedure in the OR, you have some steps who are in blind. So you may have some complication. You can have complication with the anesthesia. We know that the rate is very lower, but the rates increase with the comorbidity. You have also the complication for the hysteroscopy. Due to the blind step, you can make some perforation, bladder perforation, chronic endometritis, and many other things. You can also have some injuries in the cervix for the patient who want after to have an obstetrical future. And you have the complication of the hospitalization. It's true that when you have an ambulatory surgery, it's rare to have some nosocomial infection, but during the period with the COVID, some people enter without any infection and it came out with the COVID, for example. And when you perform outpatient hysteroscopy, you have no anesthesia, you have no hospitalization, and you have rare complication. So I will finish with this paper, who studies the hysteroscopic endometrial polypectomy and the clinical and economical data in decision making. So, first of all, the polypectomy was made for one group in the office and second group in the OR. Many criteria were studied, and the first one is the operating room, as we know, is shorter in the office. But also, this paper describes each step where you have a financial cost. It's not only the fact of you are in the hospital or not, but when you have a day surgery, you have a cost of the day surgery, the many consultations before the surgery, the anesthetic maybe, so, and the cost of the operative room. And you have also an indirect cost. You have maybe sometimes blood sample, you need to see the patient one time, the anesthesiologist one time. Also you have the cost of the day or the cost of the occupation of the OR, but also you have the cost of the laundry, you have the cost of the housekeeping, you have many costs, and also you have the cost of the day. So the result at the end is that it's lower cost to make it in the office. Once in Belgium, the activity for the moment for the last 10 years by hysteroscopy is that most of them are making in the ambulatory and in the OR. The outpatient are only diagnostic hysteroscopy, so we have a lot of job to do. And in our department, it's a retrospective study based on the last 4 years with the TrueClear. We wanted to know and to show to our department, first of all, our financial department of the hospital, the impact of the TrueClear on the OR activity and on financial benefits for the hospital, because for the moment we have no reimbursement. So I finish with that and with a question. Have we lost 150 years between what Pantaleoni had understood and what we are making to understand about the importance doing the hysteroscopy in outpatient or in office setting, because he did a first hysteroscopy in office without any anesthesia. It's what we want to do now. Because I tell the same thing that my colleagues tell you, is that Outpatient procedure, complete remove intrauterine lesion with good histological result. Shorter time procedure, outpatient setting, less cost for the hospital, more place in the OR for important surgery, rare recurrence, rare complication, and less missed work. So it's win for the hospital. Thank you.
Thank you very much, Patricia. Since we are running a little bit out of time, we had to start a little bit late because the session before the break was running a bit out of time as well. So the time for questions is rather limited. I see Sergio already looking at me. Stop this, we have to continue. I know what you mean. 2 minutes, 2 more minutes. Any urgent questions from the audience, or was everything as clear as it is when you talk about office hysteroscopy? Perhaps a poll. Let me say, can you raise your hand when you are not doing office hysteroscopy? Okay. And are you convinced now that office hysteroscopy probably is the way to go? Yes. Okay. Well, thank you very much all for the audience. We have to thank Medtronic for giving the opportunity for this mini symposium. I don't know whether my co-speakers have any comments. Attilio, do you have any comment? No, you were as passionate as always, quite clear. Patricia? No. Well, thank you then very much. And Sergio, where's Sergio? We can continue with the program. I close the mini symposium for Medtronic and thank Medtronic very much.